We're here at CRT 2014. We know from press releases that the Simplicity 3 trial has failed to reach its primary endpoint. We'll have the data in about 1 month right here in the same city for the ACC scientific sessions. Before we get there, though, at this meeting at CRT, we've been talking about this topic quite a bit in some of the sessions, and we're talking about some of the potential physiologic causes with Dr. Rob Schwartz, who's the medical director of the Minnesota Cardiovascular Research Institute. Where do we stand right now, first off, in terms of we don't have data, but is it kind of alarming to look at something like this for a procedure that has become so, it's been so exciting and suddenly it's like, sorry, it didn't work?
Oh, I think didn't work is way too strong. I think it probably did work. We certainly have plenty of data suggesting that multiple methods of denervation in preclinical models, HTN1, HTN2, it works. I think this is probably a clinical trial issue of some sort, and we need to just understand how, what, and why before we get too excited.
So you're looking at specific physiological causes?
Well, there was some question about the technique. New operators, for example, were brought into the HTN3 trial than had been used previously. The device itself, there may be some questions. The device itself had some new components to it. We have to be concerned whether or not the energy actually got out to the nerves in the same way. We're looking at an interesting possibility also, which is that specifically the importance of accessory renal arteries may be playing a major role here. That is, arteries which cannot be seen angiographistically because they are so small, maybe sub 1 millimeter in size, that just are not easily visualized unless you're looking for them. We've done a subsequent review of a randomized trial otherwise, and in fact, by CT, there are a lot of patients that have these accessory vessels that weren't seen that do have nerves that are presumably as active as the ones that go down the main renal artery.
Now, at this point in time, not knowing what's going to be released in a few weeks, and a patient comes up and is appropriate for this procedure, what should a cardiologist do?
Well, of course, it's not approved in this country yet. If you ask the Europeans, they're still going ahead as the same way it's been done all along. I think the Europeans, the key opinion leaders in the field, certainly believe this is still working. They have lots of evidence that suggests it is, and they really have not changed their practice much, at least at this point, on the basis of one study, albeit large.
Are there ongoing trials right now?
As you know, many groups have devices. They are being considered and being used elsewhere. So, yes.
So not necessarily, even those trials continue even while we await this decision?
Probably now. As you know, there have been several of the corporate entities that have dropped out of the business because of, presumably related to this trial, but I think to call the trial negative is perhaps a bit strong at this point. We didn't understand
why. Well, they didn't reach their primary endpoint. That's what we know, period.
But did the control group do just as well? And in that case, if you've got a technology that works and works as well as a person who now is taking his or her medications on a regular basis, you now have a one-time procedure that could potentially substitute for a lifetime of expensive and side effect related drugs.
And from what you see overseas in terms of data from there, you still have some confidence that this is a good approach that will eventually find a useful niche?
I'm pretty certain that's the case. You never can say for certain, of course, in this area, but I'm pretty certain this is a hiccup and not a mountain.
Oh, we'll see more from the ACC meeting, which is coming up not too long. Between now and then, please check CardioSource World News for a variety of stories from CRT 2014. I'm Executive Editor Rick McGuire.